bronchoconstriction. It is due to reversible airway obstruction, and it is due to hyperresponsiveness of airway and chronic airway inflammation. Variable intensity and frequency of episodes over time, management according to subjective symptoms. Clinical phenotypes: allergic or atopic, which is most common in children. It is associated with family, personal history of allergic condition, for example, atopic dermatitis. It has a good response to treatment. Second is non allergic, which is more common in adults. There is no family history and it is difficult to treat. And the third one is exercise induced. Fates of allergic asthma: allergen, then you have your IgE coming in, you have your mast cell. IgE bound mast cell triggers release of mediators. Degranulation starts within 10 minutes. You release histamine, which is most important, prostaglandins, leukotrienes, C, D, and E, bradykinin, everything. Treatment: beta 2 agonist that inhibits all this. And clinical features of asthma is bronchoconstriction, mucosal edema, and increased secretion. Beta agonist will inhibit all this histamine, prostaglandin, leukotrienes, bradykinin, and not cause these effects. Late phase is 3 to 4 hours later. Peak by 10 to 12 hours. Inflammatory cell recruitment. Which inflammatory cell? Eosinophil, basophil, lymphocytes. Steroids, they inhibit the cells. Repeated exposure, chronic airway inflammation. Clinical features: recurrent episodes of wheezing, cough, chest tightness, varying intensity and frequency, increased frequency late night and early mornings. Varying intensity and frequency, increased frequency late night and early mornings. Lung function abnormalities, condition and parameters. Airflow limitation, FEV1 decreased, FEV1 by FVC ratio less than 0.8. Bronchodilator response, FEV1 increased by more than 12%. Exercise challenge, airflow obstruction worsened, FEV1 reduced by more than 15%. Diurnal variation, AM to PM variation, FEV1 or PEF, peak expiratory flow, increased by 20%. So what are the lung function abnormalities? Conditions and parameters. So first, there is airflow limitation, which is shown by decreased FEV1 to FVC ratio. FEV1 decreases. So FEV1 to FVC ratio is reduced by 0.8. Bronchodilator response. So FEV1 will increase by 12%. Exercise challenge, airflow obstruction will be worsened, so FEV1 will further reduced by 15%. Diurnal variation, in the morning and then in the evening, FEV1 or peak expiratory flow is increased by 20%. Management of asthma, it's based on Global Initiative Network of Asthma, which is called GINA, Global Initiative Network of Asthma Guidelines. Management: identification and elimination of exacerbating factors and pharmacotherapy. Pharmacotherapy is long-term management and acute exacerbations. Long-term management: age more than 12 years is managed as it is in adults. More than 12 years it is managed as is in adults. Age 6 to 11 years, stepwise management. If the age is between 6 to 11 years, it is a stepwise management. Reliever therapy, short-acting beta agonist, SABA, SOS for sudden exacerbation of symptoms. Reliever therapy, short-acting beta agonist, SABA. What is the stepwise management? Reliever therapy, short-acting beta agonist, SABA, SOS for sudden exacerbations of symptoms. Frequency of symptoms and step of therapy and control therapy. So frequency of symptoms, first, less than 2 times per month. Step 1, whenever SABA is taken, uh, ICS, low dose, inhalational corticosteroids, low dose. More than 2 months, not daily. More than 2 per month but not daily. Step 2, daily low dose inhalational corticosteroids. Daily symptoms plus night symptoms, more than 1 per week. If then step 3, daily low dose inhalational corticosteroids plus long acting beta agonist or daily medium dose inhalational corticosteroids. Daily symptoms plus night symptoms, more than 1 week, more than 1 per week, plus low lung function. Step 4, daily medium dose inhalational corticosteroids plus long acting beta agonist or high dose inhalational corticosteroids. Uncontrolled on step 4. Then it is step 5, daily high dose inhalational corticosteroids plus long acting beta agonist. Biological agents are the last resort. Synergistic effect with steroid is long acting beta agonist, like for example formoterol. It has synergistic effect with steroid sparing effect long term. Inhalational corticosteroid, inhaled corticosteroid, budesonide is used. Low dose 200 to 400 microgram. Medium dose 400 to 800 microgram. High dose more than 800 microgram. Biological agents, immunomodulatory monoclonal antibodies. Omalizumab, anti-immunoglobulin E. Mepolizumab, anti-interleukin 5. Dupilumab, anti-interleukin 4 receptor. Anti-TSLP, thymic stromal lipopoietin, new drug. Anti-TSLP, thymic stromal lipopoietin, new drug. If the age is less than 5 years, preschooler. Asthma may resolve in more than 5 years in some patients. Classification of patient: episodic wheeze. Episodic wheeze during viral infection, multi-trigger wheeze during respiratory infection plus other triggers like cold, exertion, food, etc. Asthma probability: increased probability for future asthma, requires treatment. Symptoms last more than 10 days after upper respiratory tract infection and more than 3 episodes. Then you treat these conditions with controller low dose inhalational corticosteroids therapy plus reliever therapy by short acting beta agonist. If you review after 2 months and there is an improvement, then stop the treatment. If no improvement, then treat as per age 6 to 11 guidelines. Acute exacerbations and its management. Classification of exacerbation episodes: you have your mild, moderate, and severe. So sensorium, you have normal. In mild, you have absent chest restriction, dyspneial restriction in mild. SpO2 is more than 95. PEFR of percentage of predicted PEFR is more than 80. PEFR means peak expiratory flow rate is more than 80 in mild. Management is salbutamol in meter dose inhalers, STI, 4 to 10 puffs every 20 minutes. 4 to 10 puffs every 20 minutes in mild acute exacerbations. In moderate acute exacerbations, sensorium is anxious, dyspneial retractions are somewhat present, SpO2 is dropping less than 95, peak expiratory flow rate is between 60 to 80%. You give salbutamol plus ipratropium, centrally acting anticholinergics, ipratropium plus O2 to keep SpO2 more than 95%, plus oral prednisolone as well. Severe sensorium is agitated, dyspneial retractions are severe, SpO2 is dropping further than 90%. Peak expiratory flow rate is less than 60%. And management is nebulization salbutamol plus ipratropium plus oral prednisolone plus IV or IV hydrocortisone or injection magnesium sulfate. Severe management is nebulization salbutamol plus ipratropium plus oral prednisolone or IV hydrocortisone or injection magnesium sulfate. Asthma medication devices based on age of child. 12 year you have your metered dose inhaler. 4 to 12 years you have metered dose inhaler plus spacer, allows drug to be suspended in air, inhaled over few breaths. Less than 4 year you have metered dose inhaler plus spacer plus face mask. So here is your spacer and this is a metered dose inhaler. Rotahaler is not commonly used. Mouthpiece for inhalation in powdered rotacap. Hole for inserting a rotacap. Tin rotachamber rotacap powdered on twisting. We'll see respiratory infections in the next video.